is this initiative by Dr. Balasubramaniam. Is doing a wonderful job, and today is the day when he's focusing on catheter-related infections. The problem in India, one of the important problems, as Professor Amit highlighted, the second commonest cause is the PD catheter-related issues. But the problem mainly in India is why the numbers are not going up, because I can, with my past experience, tell you that there was a time in 2004 when the number of PD patients in China and in India were the same. We had about 500 patients on PD in India, 500 patients on PD in China. We are still about, I would say, 6,000 to 7,000 patients on PD in India. And the PD in China is now the highest in the world, has crossed much more than 1,20,000 now. 1,20,000 patients on PD in China. They have a center in Guangzhou with satellite centers, which has more than close to 3,000 patients on PD. So half the country of India is undergoing PD in Guangzhou and surrounding areas. What happens is when these kind of problems, mechanical issues, which we are focusing today, we're not talking about metabolic issues and other issues. There is no concerted effort by the nephrologist or the PD team to act quickly and remedy the situation. So we are having a classical situation of a frog jumping out of the well, where it jumps out and comes up 2 steps and slips down 3 steps. So we are doing probably a good number of initiations on PD, but we are not doing maintaining them. The PD vintage is very low, and also dropout rate is very high, and the quickness with which a patient is shifted from PD to hemodialysis is something which they haven't been really given a good trial of or proper counseling when there is a PD complication. So I am very happy that Dr. Balasubramaniam is focusing on these important issues so that we don't have a patient that drops out. And I'm very sure, and I hope at least, that the 3 speakers are going to give examples of how they surmounted the hurdles of PD, the catheter-related problems that they had, and how they successfully continued the patient on PD. So thank you very much, Balasubramaniam, for the PD community in India. And I hope the students here learn more and more on PD. About 10 years back, I myself remember speaking at the ISN and requesting the DNB and the DM examiners to compulsorily put a PD patient for the clinical case and put questions on PD in the theory, so that it's a incentive for students to know more about PD. So thank you, Balasubramaniam. Let's proceed with the.
Thank you, Dr. Amit and Dr. Naik. Manas, you can share your slide. Actually, after a nephrologist taking up the responsibility of putting in the catheter by percutaneous pilloway sheath, the number of PDs have increased, we all know. So we have the responsibility of identifying complications and managing them also. So I thought the reason why exactly we took up this topic today. And please start, Manas. Maybe you can, you need not give introduction about various complications and so on, and you can go to the cases. Thank you, Manas. Start. Manas? Yeah, his mic is probably. Yeah.
All right, can you see my slides?
Yes.
You all can hear me also as well, correct? Can you hear me?
Yes, Adrian.
Oh, okay. All right. So I'm going to present 2 cases with regards to the complications while placing the PD catheter. So, let's see. All right, here's my first case. So we have a 46-year-old male. He has hypertension, he's diabetic, and he has diabetic nephropathy. And he also has a distended abdomen, and we think he's probably because he's obese. And he's CKD5, and he's currently on diuretics. So he agreed to have a PD catheter replaced. And we see this quite often. Many people do not want to have a Foley catheter placed, even though our guidelines say it would be safer to place a Foley catheter to avoid complications. So anyway, we ask him to go and empty his bladder, and he does that before the procedure. So everything is good to go, and we enter the peritoneal cavity with an 18-gauge blunt Hawkins needle. Some of you may be using the Veress needle. However, when we try this, we're unable to push we are unable to enter the peritoneal cavity with the 18-gauge needle, and therefore we switch to a 21-gauge sharp micropuncture needle. That's the same needle that you all use to do your fistulograms, and we're able to enter the peritoneal cavity. As soon as we do that, when we aspirate, we find that there is this amber colored fluid that is coming out into the syringe. And when we looked at this, we thought, okay, this may be the ascites because he has diabetes and he had diabetic nephropathy as well. So let me see if I can get the next slide going. All right, so here's the initial peritoneogram. And I don't know if you can see my pointer, but here's the micropuncture needle. And you see the dye is just going away from the needle. And this is our first image. And we think this is probably is ascites. Can you all see this? Yes?
Yes, we can see.
Okay, all right. So we're not terribly concerned now. And so we start dilating the tract over a glide wire. And as soon as we try to pass the 18 French peel-away sheath, the patient complains of severe pain over this bladder area. And he tells us, listen, I need to go pee. But when he's on the table, we give him a urinal, we ask him to go pee. He tells us he cannot pee at all. So now we are having a concern that we have done something wrong. So this time we're going to shoot dye again, and we use a large quantity of dye. And what we see is this. So you can see the image on your left. Here's your micropuncture needle, and we're shooting, and you can see this weird shape that it's taking when we shoot a large amount of dye. And if you look at the picture to your right, that is the border of the bladder. And so you can see his bladder is huge. So then immediately on the table, we put in a Foley and we get almost a liter of urine in the bag. So we then repeat the peritoneogram again with the Foley, with the catheter still in the belly. And this is what we see after we have drained the bladder. And you can see it's like a ball of crumpled paper. So this is the bladder that is collapsed. So now, you have your heart in your throat and you're wondering, what am I going to do? So we called the urologist, and they did a cystogram where through the Foley, they injected dye. And what you're seeing is the distended bladder. And the fact that even though we perforated the bladder, there is no leak. It tells us that this is an extraperitoneal bladder perforation, as opposed to an intraperitoneal bladder perforation where you will see dye inside the bladder cavity. And so coming to this case, if you look at the literature, there are only 15 cases of bladder perforations while performing PD catheter placement. The most important risk factors are adhesions and anything that will cause bladder hypertrophy or bladder obstruction. Let me put it that way: bladder obstruction, which results in bladder hypertrophy. The result of bladder hypertrophy is now the bladder extends beyond the pelvis and comes into the lower abdomen. And this is the area where we put in our needle to enter the peritoneal cavity. If you have a history of adhesions, you have to be careful as well, because what happens is these adhesions hold not only the bladder, but also the bowel in the direction in which our needle is going in through the peritoneal cavity. And this also increases our risk of bowel perforation. And so I read a couple of cases that I could find online, and all those cases made the same mistake we did. That the moment the needle went into the belly and fluid came out, and this was amber color fluid, they all thought it was ascites from CKD or ESRD. So I want you all to be aware that if you get amber color fluid out of the belly in somebody who does not have ascites, please be careful. The other important thing to remember is this whole complication can be asymptomatic at all. There are cases in the literature where you'll read they put the PD catheter in, it's in the bladder, nothing happened during the procedure, the patient goes home, and during the first flush, that's when they figure out that they've done something wrong. So in our patient, we feel that this patient had diabetic cystopathy, and we relied on him to evacuate his bladder without either doing a bedside ultrasound or placing a Foley catheter. And so it may be prudent to place a Foley catheter or at least do an ultrasound of the bladder in anybody who has probably benign prostatic hypertrophy or a neurogenic bladder. What I do in our practice these days is, many of our patients have ESRD, and though we would like to place a Foley, the bladder is very small and they complain of intense pain. And so what I do now is I just scan the belly. If I don't see the bladder, I just don't put the Foley at all. I'm quite comfortable without placing the Foley at all. In others, if I cannot see the bladder, it's difficult to see, then I'll go ahead and put the Foley. And as soon as my procedure is done, I just take out the Foley because they don't like that Foley in place. And if you do suspect that you have perforated the bladder, it is important that we call urology, don't do anything. Let them come and figure out what they want to do. Extraperitoneal bladder perforations are benign. We have nothing to worry about. What you do in these people, like in our patients, is we just put in a Foley for about 2 weeks. And then he went back to the urologist, they repeated the cystogram, it was normal, they pulled out the Foley. On the other hand, if you have an intraperitoneal bladder perforation, which means dye is now entering into the peritoneal cavity, then this is a surgical problem, and then the urologist may have to go in and stitch up the bladder. So that's our first case. So do you all have any questions on the first case?
I think we will go to the second.
Okay, we'll move on to the next case. All right, so this happened recently to us. It's a 55-year-old black male with a history of diabetes, hypertension, and CKD5. So here the interventional nephrologist decided not to go with the 18-gauge Hawkin needle, but instead decided to go with a 21-gauge micropuncture needle. And so he entered the right lower quadrant, and once the needle was in and the micropuncture wire was in, he converted that, or he placed a micropuncture sheet over the wire and injected dye into the belly. So as soon as he injects, this is what he sees. So here you have the syringe, here's your micropuncture sheet, and you're shooting dye. And you're seeing it's taking this peculiar shape in the belly. So when he performed this, he called me over and he said, something is not right. And as you agree, something is definitely not right, because this is not the kind of scene that we want to see when we enter into the peritoneal cavity. So while the syringe was, while the micropuncture needle was there, I aspirated fluid, and I got this amber color fluid. Now this could be the contrast that was sitting in that particular area, or it could be something else. But it was this amber colored fluid, and because it is amber colored, that got me worried. So the next thing what I did was I went ahead and I pulled the micropuncture sheet back. And as soon as I did that, I injected dye. I'm sorry. As soon as I injected dye, now you can see right here where the arrow is, you can see dye entering the peritoneal cavity and not in the loop of bowel. So this was an example where the micropuncture sheath entered the bowel. I'm sorry. Oh. All right. All right. So when you look at bowel perforation, again, the incidence of this is very low. To us, this is the most scariest part that we've entered the bowel. When we do fluoroscopic guided peritoneal catheter placement, it's not always easy to figure out whether you've entered the bowel. And this scares everyone, especially novices who are placing catheter for the first time. So again, the risk factors, we've already talked about adhesions, but anything that causes bowel distension. So constipation, and that's one of the reasons that we like to give laxatives before we proceed with catheter placement. So there are a couple of ways where you can recognize this. The first one is when you aspirate, you might see feces. The second thing that they say is you might get a sniff test. Now, I'm kind of baffled how you will do a sniff test. Everybody wears a mask, and so it's going to be very hard to sniff. But the other thing is, if the catheter is in the bowel already, if you initiate PD on the table, then the patient will have an urge to go, or even may have diarrhea. There may be a malodorous effluent when you start PD. So these are all bad scenarios. Okay, that means if you're getting malodorous effluent, you probably perforated, and now you might have peritonitis. The other things to worry about, when you have a bloody dialysate, post-op pain. But the other thing also to remember is that the presentation may be delayed. I had one case where we went through and through the bowel, and we placed the PD catheter, and the patient was fine for 12 hours after the procedure, and he crashed in the middle of the night. So it's important to remember that the presentation may be delayed. So if you have already detected bowel perforation with the small 18-gauge needle, then you don't have to worry. You can stop the procedure and start antibiotics to cover, gram-negative organisms as well as anaerobic organisms. And it should not be for 2 days. It should be for at least 10 days. So there's a error there. And these heal spontaneously. So think about this like when somebody has diverticulitis or a small microperforation, you don't do anything at all. These lesions heal spontaneously. On the other hand, if you have placed the PD catheter and it is in the bowel, you need to leave the catheter in place, start antibiotics, and consult surgery. So how can we prevent these things from happening? So the most important thing that I at least think is necessary is to give laxatives. Now, we have seen people use this stool chart. They show the patient and ask the patient to pick what his stools look like. I'm just wary of any of those things because patients' memory is not that good, or they may not even tell you the truth. So it's better probably to put them on laxatives. The other thing that we can do before we start the procedure is to do a preoperative ultrasound of the belly at the bedside. So you want to look at an area where the bowel loop is not directly below the rectus muscle or below the area where you are going to get into the peritoneal cavity. The other thing also to look for is there any evidence of adhesions by doing what is known as visceral slide, and I will show you videos of that in a minute. Some people, what they do, as I'm showing in the diagram here, they pinch the skin and pull it up before they insert the needle to minimize perforation. And the last thing that we sometimes do at our place is what is known as a pullback angiogram, and I'll show you images of that as well. So the first thing I'll show you is how to detect adhesions. And basically what you do is you take the ultrasound probe and put it in the sagittal plane on the belly and ask the patient to take a deep breath. And what you'll see here is the bowel loops just moving. They should move by at least 3 centimeters. And you're seeing here, it's moving beautifully. And above that, what you see in blue that's rushing past you is the inferior epigastric vessel. That's the vessel that if you hit will cause a peritoneal bleed. Now, if you look at the image or the video on the right, you will see the same thing here, but here instead of the sagittal plane, I kept the probe on the transverse plane. Here you see the rectus muscle, and here below that, you will see 3 loops of bowel. And you will see the bowel loops are right below the rectus muscle. That means I cannot go in this area at all. And the other thing you'll notice is the bowel loops are not moving at all. The patient is taking a deep breath. It's hardly moving. So this is an area where there are adhesions, and you better not go in this area. The last thing video I'm going to share with you is the pullback peritoneogram. So what you have to do is you pass your glide wire in. Now, I was always told if the glide wire takes this beautiful loop like this, you have no problems at all. That means you're safe. You have not perforated anything at all. Okay. So once you do that, we put in a long 5-French sheet. Okay. And then over this, you can pass another catheter, simple catheter, 5-French catheter, and pull out the wire. Then you inject dye. And you can see here, this is called a spidery appearance. The dye is going between bowel loops, not within the bowel loops, but between. This is the kind of image we want. Then you pull your catheter is slightly higher. And that's what I have in this image. My catheter is here and I'm injecting dye and I see the same image, which is the spidery wisp or dispersion of dye. So this tells me that I'm safe, that I have not perforated my bowel. So with that, I think I've come to the end of my presentation. I'll be happy to take any questions.
Yeah. Yeah, before somebody else asks, I didn't, why should you pull back and recheck again?
Pull back what now? Say again?
I mean,
the catheter? Oh, the last image? You're talking about the last one, the pull back peritoneogram? So think about it. Let's say you use a micropuncture wire and you've gone through the bowel loop. When you pass the glide wire, it might go through the bowel loop. So that's fine. Then now, when you put a catheter on top of the glide wire and pass it down, when it hits the bowel loop, it will not go in. So on the direct fluoro, you'll see the catheter will buckle. So that's your first clue that, hey, we are in trouble, that the micropuncture wire or the glide wire has gone into the bowel. But at least now the catheter will not go through the bowel loop and you're safe. If it has gone, when you shoot dye and you keep pulling back and you keep pulling back, just like when you all do your declots, I'm assuming you all do this pullback arteriograms or fistulogram. So it's the same thing here. We're pulling back, and we're trying to see, do we still see the spidery dispersion? If it is not there initially and then it comes, that means we have perforated something. So this is just something some of us do to detect a perforation.
Adrian, you never mentioned anything about priming the abdomen before inserting the needle.
So I don't do that at all because you can get it. The question is how to get into the belly. The problem happens when you get into the belly and you're perforated through and through. So people who put the contrast or put PD fluid first in, they have to make sure they are not in the bowel first. So I never put any of that. I don't prime at all. I will get in. Once I'm safe, then I'll put the fluid in.
Yeah, but that's not the practice. We still continue to prime, and we hardly ever have a bubble perforation or a bladder perforation. I think that's something. The last slide that you showed where the bubbles were not moving, yeah, they are highly susceptible. But in a non-elderly person, if you are priming, we hardly ever see bubble perforation, and a Foley's catheter is definitely a must. These are things that we continue to practice and see very little of this. Yeah. Thank you.
Adrian, you routinely use dye to check before you proceed, or only when you suspect problems?
Always. So I think Dr. Naik was saying, he puts the fluid in. I don't do that. I will shoot this. Once I see the peritoneogram is normal, I'm fine with it. I'll proceed.
So Naik, so if he does this contrast study, then that will sort of make it safer, because if you're perforated and if you're putting in pre-filling, again, that is going to be a problem. So
Adrian, yes, you will discuss. That's right.
If I can come in, can you just, for the benefit of all of us, tell us what should be the ideal preparation of a patient before we insert a catheter? Because you see, as you realize, the end-stage kidney disease patients very often are constipated. And as a result of this, while you're putting in the catheter, if you do not have good bowel preparation, many a times you may run into this complication that you demonstrated. And so therefore, how often should we give you're saying give a laxative, but is it better to give enema the night before and also on the morning of the procedure, so as to ensure that the patient has good bowel movements? That's number one. Number two, is it mandatory to put a Foley's catheter? Because even though the patient may not want it, but it is safer to put a catheter, Foley's catheter, to avoid any bladder related complications. And thirdly, should we mark the exit point, etc., in a erect position? What is your practice at your center?
So thank you for those questions, Dr. Gupta. So it's interesting you said that our ESRD or CKD5 patients are constipated. Remember, we put them on Tums or calcium acetate. All these binders are constipating. And so the incidence of constipation is going to be very high. And so I don't rely on any of these stool charts. So what we give in our place is something called Go Lightly. It's about 2 gallons of liquid that they will swallow. They will swallow it about 7 or 8 in the evening. So I tell them at 4 or 5, eat your dinner, take all your meds. And once all those meds are in and absorbed, that's when we start the Go Lightly. So that's what we use here. It is a purgative, so it just makes you move. So all night they will be moving their bowels. And so next morning when they come, I'll do my ultrasound again, all over again, just to see that, make sure